I have the pleasure of introducing our speaker today, or reintroducing our speaker. Dr. Oller is a primary care and addiction medicine physician, serves as one of the first rural leadership fellows and chief resident at Massachusetts General Hospital before coming to UK. He's an associate program director for the University of Kentucky Internal Medicine Residency Program and an investigator for the NIH-funded Healing Community Study. Welcome back, Dr. Oller.
All right, hopefully folks can see this okay. These are our practice gaps and supporting resources. So language can be used intentionally or unintentionally to perpetuate stigma in a healthcare setting. And by changing our language, we can reduce stigma and improve the lives of people who use drugs or alcohol. Our learning objectives today continue to identify language that can be used intentionally or unintentionally to perpetuate stigma, explain the importance of using medically appropriate language for substance use disorder, and use effective terminology when discussing substance use disorder. And my outcome that's expected from this is that you guys will be able to go out in the world and utilize this client-centered and person-first language and recognize personal bias and the bias of others when treating clients with substance use disorder. So we're going to do a didactic overview, a little bit of what we covered last week. But before we do that, there's a couple of slides here that I'm going to ask you guys to annotate. And annotate, you should be able to, if you don't see a button, it's under the more category in the Zoom dashboard up top. But I want you to click on annotate and click on stamp and just press a star or a heart or a check mark, whatever you prefer. But go ahead and place a star on this slide just so that you can demo that out and make sure that you can do it okay. Thank you, John. So again, annotate, stamp.
If you're in the full screen thing, you might see a green bar that says you're viewing Devin Oller's screen, and then you're going to click View Options, and there's going to be a drop down that says Annotate.
Thanks, John. This is awesome. We're like lighting up the night sky here. Mackenzie threw in a check mark. I appreciate that, Mackenzie, keeping us honest. Okay, I think for most of you guys have got it. I'm gonna clear your stars as pretty as they are, and we'll move forward here. All right. Whoa. All right. Just a quick overview. Let me just take care of, thanks, John. One thing that can help hugely in identifying stigma and addressing it is just taking this perspective of substance use disorder as a chronic disease process. And every chronic disease has to be one that is long in duration, associated with persistent or recurring health issues, with mixed causes, usually involving some heritable component, has no definitive cure, and requires ongoing care. Actually, substance use disorder, the disease of addiction, fits all of these criteria. It's often long in duration. It's associated with persistent recurring health issues, from heart infections to overdoses to hepatitis C. It's a disease with mixed causes, and we talked about how last week about 40 to 60% of addiction is contributed to some genetic component. It's a disease that doesn't have a definitive cure and requires ongoing care. So when we compare addiction treatment to hypertension, high blood pressure, diabetes, heart failure, other chronic diseases, we see a similar pattern, that when folks enter into treatment, they're often dealing with a really high burden of disease. With high blood pressure, they might be having vision issues or headaches as a result of that high blood pressure. With addiction, they might have a recent overdose or a hospitalization for cellulitis or an abscess from injection use. And when we get them into treatment and provide them with evidence-based care, you see a huge drop-off in that burden of the disease. They're able to focus on other components of their life and other domains. And when they fall out of care, just like when patients fall out of care for their diabetes or their high blood pressure or their heart failure, well, that burden of disease starts to come back up. The WHO studied stigma and social problems and found that drug addiction continues to rank #1 year after year in terms of the social problems and their associated stigma. Somebody identifying that they feel stigmatized, that is associated with poor mental and physical health. And so we see that a lot among our people who use drugs. And it's one of the reasons that we can't access treatment. If providers or systems or institutions have this stigma towards people who use drugs, they will make it harder for them to access treatment. And we see this these data from Medicaid patients where a good chunk of Medicaid patients, 9 out of every 1,000, or about 1 in 100, carries that opioid use disorder diagnosis. But around 10 to 20% of those folks only actually get appropriate care with medications for opioid use disorder. There are really 4 different types of stigma that people who use drugs face. Really 4 categories. There's of course different types within these categories. There can be internalized stigma, and that's often after years of hearing and engaging with recovery communities or healthcare workers or just society in general and their views of drug use. But then it becomes internalized. Stigma from the recovery community, and we have a case sort of talking about that in a little bit more detail. Stigma from healthcare workers and stigma from just the overall community. We know that as a result of stigma, folks are often not offered valve replacements or other critical health interventions until they're demonstrating significant time. And I'll use a stigmatized word here, like clean, right? When clean doesn't actually designate whether that person is in remission of their disease. Denied access to housing or entrance to skilled nursing facility as a result of being on effective treatments that reduce their risk of dying by 50%. It often becomes a barrier to jobs and custody and other legal issues. So stigma sort of has this long tail that follows people around even after they've achieved remission and long-term recovery. So let's go ahead and just dive right into a couple of cases, and then you guys had some great questions I want to spend some more time on a little bit later. So for these 2 cases, when we asked about this from folks, we sort of asked, what question do you want to bring to the KY Open about this? Describe the situation, your perspective, and why you wanted to make sure that we discuss this. So using this framework, let's go over case 1. So case 1 was talking about sort of stigmatized language used in mutual help groups. And the problem that the submitter said was, they had this client who had opioid use disorder and was doing well on buprenorphine, naloxone, or Suboxone. They were also attending NA meetings, and they got a lot out of those meetings, but they're hearing, Suboxone called a crutch, that you're never clean while on Suboxone. And so they started tapering Suboxone and developed more cravings and urges to use. Actually ended up having a slip. The guy got back into care, but in talking with their doctor, they still had a lot of concerns about this idea of needing a crutch. And this is the perspective of the person who submitted it. And they sort of said that it was really challenging, was this internalized stigma, bad experience with prior bad experiences with a doctor, bad experience with medication, and sort of struggling with, what's the best way to describe the disease model in a way that somebody can connect with. So I'm gonna go back to this slide, but just for a second, thinking about this situation and using our stars or check marks, how comfortable would you feel addressing this issue with a client? Go ahead and put a star where you think you're at right now. Awesome. So let's dive into that in a little bit more detail. For folks who were maybe up towards the 9 or the 10 range in terms of totally comfortable, what would be some approaches, some tips that you would have for somebody who's maybe a little bit unsure about how to move forward with this conversation with the client? So Millie, great. Let them know you do not judge them. You want to hear their story. So that's a great opening, right? Of jumping into it and saying, I'm here to listen and try to understand where you're coming from.
I would maybe talk to them about the fact that there's other recovery programs and meetings than traditional 12-step.
Yeah, so can you talk a little bit more about that, Nick?
Yeah, sure. Well, here at Voices of Hope, we have MARA, which is Medication Assisted Recovery Anonymous. It's offered in the room and hybrid on Zoom. And then there's also Smart Recovery, which is something we offer here, but also it's offered, all over the country, as well as MARA.
I think that's a great point, right? Of letting the client know that there's other options out there, right? They have to, number one, feel safe and welcome and comfortable in those meetings. And so finding them a meeting that fits those needs is really critically important. The client was saying that they were getting a lot out of the meetings. I think it's also useful to explore with them, what they were getting out of that, right? Tapping into that motivation that they might have, how it might be helpful to them. Was it helping them, begin to form some positive sort of social networks again? Was it helping them get just some hope back, and hearing people doing well in sort of long-term recovery and remission? Was that sort of what was drawing them to it? So by talking about those positives, we can reinforce the motivation to try to get them to a place that they can still get all those positives out of it and lessen the negatives. How would you coach this client if sort of the crutch, about this idea of a crutch, right? What would be sort of something you would say in response to that? Suboxone is a crutch. How would we respond to that? Yeah, so Shannon says we talk about how MOUD has been proven by the FDA to use for substance use disorder, and it can be long-term. We use motivational interviewing to see if there's a deeper root of why they believe that. Also talk about the proof of others living life productively with the medication. And I think that's really powerful, right? If you're only hearing stories of people who are doing well without the medication, it can be really nice to hear stories of people doing well with it. Tanya gives a great example of using an analogy, right? Going back to the disease model, right? These are both diseases. They're chronic. They don't have a simple treatment. But in the same way, diabetes doesn't have a cure, but we don't call insulin a crutch. High blood pressure doesn't have a cure, but we don't call blood pressure medication a crutch, right? And medications for opioid use disorder is the same. In fact, they're better than those drugs that we use for diabetes or high blood pressure when it comes to reducing the risk of death.
I also had an issue to come up yesterday where a gentleman that I was working with was put out of his recovery home because they said he was depending on the shots as a crutch. He was using them as a crutch. And he called me and he said, but my doctor has prescribed these and I'm doing well on it. What do I say? And I said, well, first of all, you need to talk to them and tell them and let your doctor get with them to tell them. And he said, they won't do it. Then after several conversations with them, as well as with the recovery center, we found out that they were a non-MAT recovery center, but he was not aware of that. at the time he went in. So I think there needs to be clarification, not only within the person, but within the facilities that they're going into. Because he said, I felt like I was doing better. Now I feel like I'm just a druggie again. And I said,
Yeah,
no, you're not. You're getting
right.
medication, which is what you need. So we found him somewhere else to go. So that worked out. But
Yeah, I hate to hear that. At the same time, we know that that's really a common issue, and I'm sure others have similar stories that they've dealt with working with clients. I think the other thing to point out when sort of scoping out, is it a good fit for somebody who's on medications for opioid use disorder, is asking that facility whether there's protocols or requirements to taper the medication, right? So they might say to you, yeah, we're okay with them being on this medication, but you sort of dig a little bit deeper and they really push sort of tapering Suboxone while they're there. And again, that should be a doctor-patient discussion about the risks and benefits of that medication. And they should not be feeling that external pressure to stop. It should really be what they want in conjunction with working with their doctor. I'm wondering if others have other ideas for addressing this issue. Millie brings up.
I think one thing that was involved in this was that the gentleman was not aware that they were a non-MAT facility. He had already had a couple of shots before they told him that he had to leave, and it was a surprise to him. So I think more clarification as to what they will and will not accept at the beginning, from the get-go, would be an important step for them to take.
Absolutely.
I definitely agree. And just something that I do is I always have a prepared list of several places that will accept him in a MOUD, as well as methadone, because that's hard to find.
Yeah, and asking also about, that client, especially early on in care, they might be dealing with significant mood issues, depression or anxiety, and might be taking, SSRIs or other medications for that. And so asking if those medications are okay. You would be surprised about, some medications that facilities say they're not okay with, right? And it comes back to stigma. We still have a lot of stigma around depression, anxiety as chronic diseases that have effective treatment and management strategies. And we really need to try to address that head on. Okay. Let's jump into case 2. So again, same framework here, problem, perspective, and purpose. So this was somebody who basically asking how we should call out stigmatizing language used by coworkers. And they were seeing a client with opioid use disorder and developed cellulitis and abscess of the right arm. Coworker called the patient an addict, said that they would never get clean, and they didn't know what to say to this coworker. And their perspective was they were sort of feeling like, I'm the lowest person on the totem pole of this care team. It was thinking about, if this was, you're saying to the coworker, if this was your family member, how you would treat them, but wasn't sure sort of how that would come across. And they were feeling like there needs to be education across the board to address stigma. So we're going to do the same thing with this case as we did with the last case. So trying to think about addressing stigmatizing language used by coworkers. How comfortable would you be in addressing this issue? I was getting worried there. I was like, you guys are all up in the totally comfortable. I have nothing to teach you. This makes sense, right? People would feel sort of a spread along this spectrum. John Lochner does not like conflict. I feel you, brother. Okay, so why don't we stop the annotations, and I'm going to clear those, and we're going to go back and discuss the case in a little bit more detail. All right. So this was specifically, I think, in the hospital setting, but you can sort of extrapolate it into the outpatient setting as well, or whatever setting you work in. But basically, a coworker says something like addict or never get clean. What are some tips or strategies that you might use in addressing this with them? So Candy says, restate what they say using appropriate language, right? So we talked about this a little bit last week, but maybe that is not the moment. They might be feeling vulnerable or have really strong emotions about this case. That might not be the moment to say, hey, we never use that language about patients, but rather use some reflective listening. But when you're reflecting back to them, use sort of the correct terminology, right? If they say, I feel like this person will never get clean, you can reflect back, it is really frustrating and challenging sometimes when we're seeing folks with opioid use disorder not get into long-term remission, right? And so that you're still sort of listening to them, you're still meeting them where they are, but sort of shifting that perspective a little bit. I think Millie makes a good point that I think if not in that moment, then later making sure that they're aware that their language can affect this individual, it can affect and create more barriers for them getting care, right? I think coupling here's the correction and here's why it's important is always good, right? So we try to avoid using the term clean or dirty. That can add to stigma that somebody who uses drugs has. And we know that stigma represents a barrier to them getting effective care and sometimes seeking help as well. And I think we are all on the same page that we want to try to get as many people as possible into the care that they need. So sort of aligning around that shared mission that this person likely has. What like raising the stakes a little bit, what if they used like clean or dirty or addict like in front of the client? Would that change how you would approach it? Like sounds like it's just in a huddle sort of talking through what this individual with opioid use disorder is struggling with, but what if it was sort of right in front of them? I know we have a lot of our recovery coaches on the call today. How would you guys feel about sharing sort of your own perspective or your own experiences with stigma in that moment? Do you think that would be a effective way of sort of getting somebody to change that behavior? Nick makes a point of, it's often unclear sometimes with coworkers or the amount of experience that they've had and whether they've had this education, right, about stigma and its impact. So it can be tough to know how to intervene in that moment. How does this language make you feel? Sure. I think it'd be well within your role to really say, I'm just going to pause our conversation right now because something was said that I think is important to highlight. And there was a term, clean or dirty, that we try to avoid because it creates more stigma. It creates more barriers for people getting the care that they need and staying in care. And that might not have been intentional, but it can still hurt sometimes hearing that term be used. So I just want to acknowledge that we're just trying to do better for you, the client, in this moment. Yeah, just trying to frame it as, providing a little bit of education. Yeah, or correct them immediately. Right. So if you correct them immediately, I think you still want to go back afterwards and sort of debrief on that. One, to sort of cushion the blow of maybe that's somebody who looks up to you or is working under you, but you want to sort of go back and say, hey, like, I interrupted because fill in the blank, because this is a really important topic to me, or this is something that I really care about, right? And I feel frustrated and sometimes a little bit angry when I hear that. You might have used that unintentionally, right? It might have just been second nature because you hear other people saying it. But it is really important that we get this right. Shannon says, I've shared with my PC a lot about my use and how people address me in healthcare situations. And she has been more than polite about it. She says sometimes that is wrong or offensive to let her know that she doesn't say it to others. Thanks for sharing that, guys. Any other thoughts on this case? Okay, cool. Well, thanks for that great discussion. We're going to switch gears. There were three key questions that you guys submitted, but certainly if there's others as we're going through, go ahead and jump in with them. So this was a really interesting one. Do you think popular depictions of the opioid epidemic help or hurt stigma? Shows like Dope Sick, features on John Oliver, or documentaries seem to be more frequent. How can we use these shows to help address language and stigma? So there's been a few studies of actually media depictions of opioid use in the epidemic. And one thing that they all share is that they often have this component of agenda setting, and they often have this component of framing. And so when I am consuming these media, whether it's a newspaper article, television show, documentary, I'm often asking myself these questions, right? Because they're entertaining, they're fun to watch sometimes, but I want to sort of not just watch it without interrogating this a little bit more. So the questions to ask is with agenda setting. So this is idea of, often media depictions have agenda around them, right? Is there a policy prescription that the producers, the editors, the writers of the show have for tackling the epidemic? And framing is also important, right? So we're hearing this narrative through a handful of voices, right? Which voices are given more weight, right? What voices are absent from the narrative that's being depicted? And just as an illustration, let me go ahead and pull up here, or stop share for a second, or pull up or pull up a video of the Dope Sick TV trailer, just to give you guys a glimpse of this.
Most
Can you hear
people
that?
don't think about us up there in the mountains. Many of my patients are minors. It's dangerous work, and they carry the burden of building this nation on their backs. They're in pain. These people, my people, trusted me. I can't believe how many of them are dead now.
We've begun looking at something that could be big.
OxyContin.
Purdue Pharma, they've been marketing the drug as something that's non-addictive when it clearly is.
All your doctors are going to be asking, how is this even possible? Your most effective talking point are these magic words.
Less than 1%.
Less than 1%.
Less than 1%.
Less than 1.
They told me that less than 1% would become addicted.
If OxyContin does what I think it can, it could soon become Purdue's first billion-dollar drug.
Purdue continues to lie about the drug's safety to doctors, to patients, and the FDA. We have a major case here.
Addiction rates, overdoses, and crime are on the rise across the country because of this drug.
I think maybe the medicine might be just a tad more addictive than you said.
I can't live like this anymore.
Our community is ground zero for a national catastrophe.
Purdue will not move unless we punch hard.
This is not our fault. These people want to be addicted.
I want top executives to feel some pain.
It's crucial they understand we've created the greatest painkiller in the history of human civilization. I think I can make this the biggest drug in the world.
All right. So some might have watched that show. I personally haven't, but just from the from watching the sort of intro, when you think about this first question, what policy prescription does the show have for tackling the epidemic? What are some of the responses or reflections that you have? Who are basically the good guys here? Definitely not the pharmaceutical company. Yeah, so it's easier to say, okay, they've set up a clear villain here, Purdue Pharma. But who is it sort of depicting as the good guys? Yeah, so government investigators, government minors, right? Minors, I feel like they're almost depicting as sort of collateral, or the local doctor. Yeah, but yeah, and sort of like the DEA, right? And actually, looking back at sort of the early years of the epidemic, like the DEA actually missed a lot of this, and didn't enforce when it should have, and we're just now sort of seeing settlements out of what happened almost 20 years ago, right? And so that is a little bit of an interesting sort of agenda setting of making sort of the like law enforcement basically the main good guy, right? When we know that a lot of these communities, it was a joint effort to get a lot of the things under control. And then the second sort of thing to ask about, so framing. So what voices are given more weight in the narrative? What voices are absent? What do we think about the framing of Dope Sick? And maybe this changes in the actual show, but at least from the trailer, there's a few things that stand out. Yeah, so we don't hear much from the minors. We don't hear much from the people struggling with addiction. I think there was just like one snippet of the woman looking at pills and sort of saying, I can't live like this, right? The patient's voices are absent, right? And again, maybe that depiction changes a little bit, but what they are pushing, right, is this narrative of there was sort of this one bad guy, Purdue Pharma, that poured a bunch of pills into these smaller communities, and then there were a lot of victims from that, right? And the DA came in and was able to extract a lot of money from Purdue Pharma for all this wrongdoing, right? And so it doesn't necessarily position the patients, the minors, the community from a place of agency, from a place of they actually seize control and were able to do something about this, and that can be troublesome. Thanks for sharing that, Millie. It doesn't sound like the patient's got much voice in there. So coming back to the original question, I think overall, it is a good thing that there are more popular depictions of the opioid epidemic, but the way that it reduces stigma is a little bit less clear to me, right? You reduce stigma when you develop through that depiction more empathy for the people who are struggling with opioid use disorder, right? You reduce stigma when you see the solutions as something that can be community-based and not just the DEA saying that we're going to change things up, right? You're going to reduce stigma when these depictions are of people that look like the people that you go to school with or church with or work alongside. So I think I'm always a little bit hesitant around this, but I think it has a lot of potential that has been untapped currently. Any other thoughts on media depictions? Any other shows that we should be watching or you feel like do a better job of this? And I was talking to John before we started, a lot of this like hits a little bit too close to home for the work that we're doing, right? We want to have something at the end of the day that provides us a little bit of escape or entertainment, and it's hard to detach yourself and just watch this and be entertained by the characters or the story. John lists a good documentary, The Crime of the Century, talking about Purdue Pharma. Yeah. But again, I think the caution there is it wasn't them who were potentially jeopardizing the patients' lives. All right. Are you seeing policy changes that might make it easier to address stigma around substance use disorder? So moving on to our second question here. What can people do to advocate for the fair treatment of people with substance use disorder? So I'll tell a personal story. So I came to University of Kentucky about 4 years ago. And at that time, myself and just a few other providers were actually prescribing Suboxone. And we did not have inpatient addiction consult and education service or ACEs to help serve the needs of people hospitalized with complications from substance use disorder. And when we started that inpatient consult service, there was a lot of stigma still. And not saying that it erased stigma, but over time, we've seen more and more a culture shift where in the notes that people write about patients, I don't see a lot of the term abuse. I see more substance use disorder, opioid use disorder, alcohol use disorder. I see MOUD pop up in those notes all the time, right? I see more focus on the barriers to getting people into care once they are released from the hospital, then trying to find ways to get the person out of the hospital because of concerns about behaviors, often driven by untreated withdrawal or untreated pain. And so sometimes it's hard to see those policy or those institutional changes make a difference in those initial months or even sometimes years. But the ACE is a good example of why it's important to stick with it and follow through, because you will change hearts and minds. In terms of other things that are helpful for you to know about, so there's increasing focus at the government level in identifying and trying to bring to justice individuals who are violating the Americans with Disability Act. The Americans with Disability Act, which was passed in the late 90s by the Clinton administration, put forward a lot of rules that protect people with disabilities. And that can be both physical and mental health disabilities. And so opioid use disorder and other substance use disorders are included in the conditions that the ADA covers. And so just by vote here, and you can put this in the chat, I'm going to ask whether this is a violation of the ADA or not. So each of these have associated sort of case with them that went through the courts. So for example, a city terminates an employee based on his disclosure that he completed treatment for a previous addiction to prescription opioids. Is that an ADA violation or not? Yes or no? Good. Lots of yeses. Absolutely. Right. And that one is especially egregious, I feel like, because this is somebody who is now in long-term remission, who by all intents and purposes has their chronic disease under control. It's not impacting their daily life, and they're denied employment. Okay, how about the second one? A doctor's office has a blanket policy of denying care to patients receiving treatment for opioid use disorder. Violation, yes or no? So I'm seeing some yeses. This is an ADA violation as well. And I think what happens oftentimes is doctors' offices or other institutions are not as obvious about it, right? They may not have written down a policy of we don't see patients with opioid use disorder, but they may put so many barriers to them getting effective treatment that nobody is actually seeking care there, right? So, and unfortunately, there isn't the same sort of level of protection from that sort of intentional negligence than as there is from sort of intentional exclusion of patients from care. How about the third one here? A drug rehab program asks the participant to leave because that participant routinely breaks a rule prohibiting the use of illegal drugs while in the program. Is that a violation? Yes or no? Okay, so you guys are getting this one. So this is actually not a violation. And active ongoing use of illegal drugs is the main thing that protects that institution from a suit involving ADA violations, right? Now, if they ask the participant to leave because they are now disclosing a history of a certain drug use, then it would be closer to that first example. And then the last one, a skilled nursing facility refuses to admit a patient with opioid use disorder because the patient takes doctor-prescribed medications for opioid use disorder, and the facility prohibits any of its patients from taking medications for opioid use disorder. The violation? Yes. Yeah, this is one that we run into all the time. And there was a pretty big legal case up in Boston around this, and the skilled nursing facility ended up settling with the client for a fair amount of money for infringing on their ADA violations because they were on buprenorphine and they were refused care at that nursing facility. But again, I think a lot of facilities are less obvious about it. They may not say that they refuse all patients who are on Suboxone. They might say instead, we don't have the means to, set that person up or prescribe them Suboxone when they leave the facility. And so we're hesitant to continue it while they're there. And so on the inpatient side, we often are working with skilled nursing facilities to set up bridge scripts that they can have on hand when that patient leaves, and to get them covered until they're able to get into clinic. But it gets messy. So if you are concerned that a client is experiencing ADA violation, one of the best ways that you can advocate is actually providing the ADA, the .gov website or their phone line with that information. And often they put out specific calls looking for multiple cases to sort of bundle and put together into a suit. But these are things that I think certainly talk with your supervisor. But if you guys feel like, hey, this is a clear ADA violation, that should definitely be reported, because that can impact policy very quickly. We also have some upcoming policy changes at the state level, basically regulations around opioid treatment programs or methadone clinics. Public comment is actually open right now on those regulations, and it has a submission deadline at the end of next month. This is a good contact person, Krista, if you have specific questions. But the QR codes are here, and maybe John, if you can put those links in the chat as well so people can reference them. Okay, so any other questions or comments about policy changes and stigma? So this was an interesting one, right? So has the legalization of cannabis in some states changed the stigma of that substance? So when we last week when we talked about sort of stigma and opioid use disorder, I made the analogy to where things were at in the late 80s when HIV/AIDS erupted, mostly in New York City and San Francisco, and how that epidemic was sort of pinned on men who have sex with men, and by making them an other, by making them sort of the culprits, it ignored the significant risk to people receiving blood transfusions or having sex with partners with HIV exposure. And it wasn't really until Ryan White, a young kid with a cancer diagnosis requiring significant transfusions, when he developed HIV/AIDS and died, that we saw major changes in how the public sort of perceived that disease process, and changes in how the government educated the public around HIV/AIDS. And that individual's name is Ryan White, and that's familiar because that's the name that all of the state HIV programs are named after. So cannabis has an interesting history as well. So this was a New York Times article from 1925, so almost a century ago. It says, kill 6 in the hospital. Mexican crazed by marijuana runs amok with a butcher knife. And there were multiple spellings of marijuana in the past. You see like J, you see H, you see G sometimes. But you can see a similar pattern here to what we were talking about with the HIV epidemic, is let's call this drug something that has been around for long before the 1920s. So cannabis and hemp have been in cultivation for centuries before this. But as we're seeing sort of an uptake of cannabis use in our society, let's sort of create this scary entity that is responsible for sort of corrupting our youth, our society, and then let's call the drug that they use something that sounds like their own language, right? So it took sort of a Spanish name, marijuana, and sort of started using that with regularity and referring to cannabis products, right? So by setting up that stigma, they hope to sort of dissuade people from using the product. And so you develop this vicious cycle where you have stigma associated with the use of the substance. And then you have this process of otherization by which you sort of frame as an outcast people who are using that substance. once you have framed them as an outcast, as somebody who's not contributing meaningfully to society, it's easy to see that one solution to that is criminalizing that behavior. And then once you start having more criminal association with the use of that substance, well, guess what? That increases stigma as well. And then that cycle just goes on and on and on. And so with cannabis, what we've seen is by sort of addressing the criminalization piece, there's ways to potentially reduce some of the stigma associated with this. As a reminder, and this is something that I feel strongly about too. So the American Society of Addiction Medicine has recommendations for non-medical use of cannabis. And they basically say cannabis use should be discouraged through evidence-based prevention programs because of lack of evidence around its use for a variety of different medical issues. But cannabis should be decriminalized and civil fines and fees should be eliminated, as these disproportionately punish people with limited means, right? And states that do legalize cannabis should use models other than commercialization. And they make the point that rampant sort of commercialization around tobacco and alcohol products certainly worsened the development of alcohol use disorder and tobacco use disorder in the 20th century. So that's sort of ASAM recommendations. So I think that it's a mixed bag. There's now, I think, 35 states with either decriminalization or medical use or legalization of cannabis use. Kentucky is not one of them right now, but there's right now in the legislature coming up here, their session, they talked about last session, they're going to talk about it again this session about potential medical use. And so I think what we've seen is a mixed bag across the country, where in some states we're seeing less stigma associated with it. No change in stigma, or if anything, increased stigma around opioid use, because it's then perceived as like a hard drug, right? Or different than cannabis use. And so this is a really challenging thing to cover. I will give you, though, a historical reference point, which is in around that same time that they were describing the marijuana craze sweeping the nation. Bayer, who makes aspirin and still makes aspirin, was advertising as a sedative for coughs, heroin, and you could buy it in this little bottle, right? So I think it will be fascinating to see sort of how stigma around these substances change in the coming years. But what it illustrates best here is that we as a society actually get to choose what's stigmatized and what's not. But it's only through sort of collective action and empathizing with people who are struggling with this chronic disease of addiction that we start to make a major difference and impact in their lives to reduce the stigma associated with that use. But I welcome other thoughts or ideas, or if you have other specific questions about cannabis and stigma, let me know.